Good morning everyone. So I am Dr. Ambuja Shekhar, Assistant Professor from Department of Microbiology. Today my topic here is Vibrio Cholerae. So Vibrio Cholerae is one of the leading cause of gastrointestinal infection. So we are going to look in detail about it. So the basic characteristics of Vibrio Cholerae is darting motility. It is a curved gram-negative bacilli which is actively motile with a single polar flagellum. These belong to a strong aerobe family, and then they are optimum salt lovers. They are usually found in marine environments, and there are around 12 species which are pathogenic. And the most common species that cause infection is your Vibrio Cholerae causing cholera. And initially it was classified based on their salt requirement. It was usually considered as halophilic as well as non-halophilic. So halophilic Vibrios, usually the salt is very highly necessary. Around 7 to 10% of sodium chloride is needed for them. The examples include Vibrio parahemolyticus, Vibrio alginolyticus and vulnificus. Whereas a non-halophilic Vibrios, they can grow without salt. Even 1% salt is probably needed. And the examples are usually Vibrio Cholerae and Mimicus. And then came the proper classification of Gardner and Venkatraman. So here Vibrios are classified based as Group A and Group B. So Group A are the one that has your Vibrio cholera Vibrios. Usually they are all similar but with a common H antigen. So this Group A was then divided based on somatic O antigen into O1 and non-O1. And then following that, this O1 was again divided into classical as well as LTOR. Following that, it was this classical and as well as LTOR were also divided into serotypes Ogawa, Inaba and Hikojima. So this O1 serotype was actually agglutinated by O1 antisera, and this O1 serotype is responsible for all the pandemics and most of the epidemics of cholera. Whereas this O139 serogroup that was initially since 1992, it has caused several epidemics as well as outbreaks along the coastal India as well as Bangladesh. And non-O1 or O139 serogroups usually cause occasional sporadic outbreaks of diarrhea and intestinal manifestation, but never an epidemic. So biotype, like I said, there was classical as well as LTOR biotype. And classical biotype, it was responsible for the first 6 pandemics of cholera everywhere, and it was highly virulent and had caused a lot of death. Whereas your LTOR was the one that replaced the the classic biotype in the final epidemic by around 1961, causing the 7th pandemic of cholera. So this is the differential characteristics of Vibrio Cholerae biotypes, that is a classic as well as LTOR. So you can see the differences here, that is your hemolysis of sheep RBCs are positive in LTOR whereas negative in classical. There is agglutination of chick erythrocytes in LTOR whereas negative in classical. Vokes-Prosker test is positive for LTOR whereas negative for classical. Polymyxin B sensitivity, they are sensitive for classical whereas not sensitive for LTOR, and they are susceptible to certain phages. The Mukherjee group 4 phage was positive for classical, whereas LTOR phage 5 was negative for classical, as well as vibriostatic agents are positive for classical. Coming back to your serotypes, O1 serotypes were again divided into 3 things, that is your Inaba, Ogawa and Hikojima, based on the minor antigenic differences of the O antigen. So Ogawa is the most common serotype isolated from clinical samples, followed by Inaba. However, during the epidemics, shifting between the serotypes can take place. More common between Ogawa to Inaba, which occurs due to the mutation of the RBT gene. And Hikojima represents an unstable transitional state, and where both Inaba as well as Ogawa antigens are expressed. And coming to the virulence factors, the main thing that we have to remember here is your cholera toxin. So this cholera toxin is the one that is causing the whole pathogenesis that we'll be seeing next. And this is the one that causes hypersecretion of your electrolytes and water. You have something called as the co-regulated pilus. So this pilus is going to help adhere to the mucosal cells. And then comes your adhesin, the accessory colonization factor, which helps in the whole adhesion of the organism into the stomach mucosa. Then comes your hemagglutinin protease, releases the bacteria from mucosal cell. Then comes zona occludens, accessory cholera enterotoxin, which these are the exotoxins. And then you have flagellum, this is helpful for motility, and the siderophores for ion sequestration. So coming to pathogenesis, like I said, the cholera toxin has 2 fragments, that is A and B. So B is the binding fragment, so it goes and binds to the GM1 ganglioside receptors on the mucosa, and then following which A gets internalized. Once inside the cell, it is going to cause ADP ribosylation, which causes accumulation of cyclic AMP, and this accumulation of cyclic AMP is going to release all the chlorine and sodium into the gut lumen. So once chloride and low sodium goes outside the cell, this is going to attract a lot of water, and this is going to cause a lot of electrolyte loss and thereby causing diarrhea. So this is what the clinical features comes to. So most commonly they are asymptomatic. Some of the characteristic symptoms of cholera include watery diarrhea, stomach pain, leg cramps, mild fever, vomiting, sunken eyes, dry mucous membrane access, decreased output, all because of because of loss of water. And this is the characteristic rice water stool in cholera, as well as there are signs of dehydration. And coming back to the epidemiology, usually cholera was initially identified along the areas of Ganges as well as Brahmaputra, where that is considered as a homeland. From there, it started spreading to all other places. And talking about the pandemics, the first 6 pandemics from 1817 to 1923, which was caused by a classic biotype. And then your seventh pandemic, which was caused by a Delta type. It was actually only paratype, the only type that was outside, originated from outside India, from Indonesia. So it caused a mild infection and had more carrier rates. And what is a carrier here? So carrier is someone who's going to carry the infection, sometimes subclinically, but you can't just put in a word like that. So we are going to define the carrier into 3 stages. That is preclinical or incubatory carriers. They have a short incubation period of around 1 to 5 days, and these are they become potential patients. Whereas you have a convalescent carrier, so these patients recovered from an attack of cholera may still continue to excrete this during their convalescence or 2 to 3 days. And the stage due to patient not having any proper treatment of antibiotic, it can lead to chronic or long term. Coming next is your contact or your healthy carrier. So these are subclinical infection acquired from cases or carriers, and their duration of around less than 10 days, and their gallbladders are not infective, and the stool cultures are frequently positive, and they play an important role in spread of the disease. Coming to the lab diagnosis, you have the specimen, which is a watery stool, or you can also collect from rectal swab for carriers. These are transported in a Venkatraman Ramakrishna medium or Carey-Blair medium. And on direct microscopy, you can see this curved gram-negative bacilli. And this stool specimen can be enriched by use of alkaline peptone water, and following which it can be streaked on selective media like TCBS and McConkey. So once grown, you can identify based on biochemical reactions. You can go in for the biochemical, can go in for species specific. Then comes your management, where there is fluid management is the base for all these diseases, where especially diarrheal diseases. So first and foremost, you have something called as fluid management with IV fluids or oral ORS fluids. Antibiotic use is very minimal, but only in case of severe dehydration this can be used. And how do you prevent it? So in general, following proper hand hygiene procedures would actually avoid this disease at all. So washing a hand with soap and water, following hand hygiene, drinking use of safe water, cleaning up properly, having a good personal hygiene, and consider getting vaccinated, cook food well kept it covered and eat it hot without any infestation of flies or anything. And the prevention here comes with the help of vaccines. So you usually have killed vaccines. So the killed vaccine are 2 types. There is a whole cell, 2 doses, 2 weeks apart. And there's a whole cell recombinant B subunit vaccine, which is usually given 2 doses, 1 week apart, given for more than 2 years. And it gives a protection for 2 years. Whereas this whole cell plain vaccine is going to given more than 1 year. It is going to give you protection for 3 years. Thank you.